Hello and good afternoon. My name is Fred Trotter, and I am a healthcare data journalist with CareSet Systems. And I am absolutely thrilled to be interviewing Dr. Shaikh from Amazon's AWS for Public Health. And he is not only with Amazon now and doing really exciting things he's going to tell you about in his current role, but he is also a longtime Datapalooza attendee. He's been involved since the very beginning. I'm really excited that he attended the first Datapalooza, which I'm super jealous of. I gotta let you know. But before we get started, I just wanted to talk about Amazon Web Services. This video is for the patients who could not attend Datapalooza, and of course, we hope that other audience members enjoy these videos. But I'm really focused on helping patients understand what they might have missed. There's a lot of cases where patients can't travel to come to Datapalooza, and as part of our commitment to accessibility at the conference, we continue to kind of produce a little bit of lightweight content that will let you know the kinds of things that were discussed and the ways in which collaborations with the federal government and with data policy in general are coming out at Datapalooza in the way that patients need to know. With that in mind, it's really hard to underestimate the impact of AWS, Amazon Web Services, on the whole world. Obviously, Amazon starts as a bookstore, and then they develop this infrastructure that is so reliable that they start selling their infrastructure and they're scaling web infrastructure for all purposes. And in general, AWS has gotten more and more into different industries. And for many years now, there have been revolutionary access to GPUs and other things that you need to use in order to do bioinformatics processing work with DNA and other omics data set, proteomics, genomics, connectomics. I mean, there's a bunch of them. And AWS has been offering specific services of that. But relatively recently, they've started to expand into other things that might be considered traditional health IT and public health. And when you start to get into public health, then Dr. Shaikh and his team are even more involved and more centric, and they've come to Datapalooza as a sponsor. So that's the background on AWS. I have pulled up the AWS page here for you to look at. This is a good place to start because from here you can get to all those other various things that I said, including the subsections about public health. And there's a lot here. And if you are a patient in the United States, I think it is probably inevitable that your data is processed, probably anonymously, on these systems and all these services by your hospitals, by maybe an ACO that you participate in, or a public health agency. And in general, the value that is provided to patients by leveraging their data that's coming in one way or another from AWS is probably extraordinarily significant. So these are very important systems. However, for me, I have a super soft spot for AWS healthcare just recently because I've been working on regulations data. So I've been working with Moravian University on a project to publish the comments on regulations in a way that is machine readable as a corpus that can be analyzed. And I wanted to do that precisely because there's a huge number of very controversial topics that the public comments about on healthcare policy topics, and I want to know what they say. And I didn't have that corpus available, so I've been working with Raven for many years to make that an open data set, and it now is. I think it's about 6 months ago that it's been out. But the big announcement that we made at Datapalooza, and here's the other thing I want to show, is the Mirrulations Project is now approved as an open data set on AWS Data Exchange. As Dr. Shaikh and I were just briefly going over, we originally published it using S3's download or pays functionality, and S3 is a way to host raw data files on the internet. But we were uploading terabytes of data, and if our data set took off in popularity, it could easily create a huge bill from Amazon. And so by using the S3 download or pays, someone could pay Amazon $50 or $300, depending on whether they want to adjust the text or the images, and download that whole corpus. But now, rather than you having to pay $50 or $400, AWS is sponsoring those downloads, which is a huge big deal for us. And I hope a good example of a data set that you could now feed back into the kind of systems that Dr. Shaikh is going to be talking about potentially here to learn more about patient needs. So I'm going to stop sharing my screen. Here's the Mirrulations page on, this is the software that downloads the regulations. Here's the Moravian University resource on how to work with the data from Moravian. Here's the GitHub repository that I maintain in order to work with this data. And we will add all of these to the show notes so you can easily get to them. With that, I'd like to stop talking, and you can see I'm pretty excited about the potential of AWS. I could be one of your salesmen. But thank you for joining us so much. Would you introduce yourself, introduce your history with Datapalooza, and what brings you back this year?
Thank you, Fred. I'm really pleased to be here. As you mentioned, I'm one of our leaders at Amazon Web Services. I'm on our global healthcare team, and so I lead our population health strategy. And so what that entails is really helping both our customers and working with our partners as they think through how to harness complex structured and unstructured data. So EHR, claims, operations, patient-generated data, data of all types. And with population health, the way we've defined it at AWS is that data are really proxies for drivers of health, right? The genes, behavior, environment, all the different social drivers. And those proxies are really meant to help our customers look at what their priorities are around quality, around cost. And so it's both clinical as well as community or public health interventions and interoperation between payers and providers. And that's where I think population health in some ways is a little bit broader in some ways than just public health, depending on your definition. But for myself and my background, as you mentioned, I've been really fortunate to be a part of the proceedings at Health Datapalooza. And when it was first launched out of HHS, and some of you might remember, it was called the Health Data Initiative. And so for me, I find it incredibly gratifying to be able to participate and support these proceedings, because I don't think there's any other conference where you have the level of representation across government, both federal as well as state and local government, but also their engagement with industry, with nonprofits, and with patients at the center. And what excites all of us, I think, when we attend is the need to be able to look at how can we be more innovative with harnessing data for better patient-centered care and outcomes and empowerment of patients. Fred, the other thing I do want to mention as well is that at AWS and Amazon Web Services, all of our customers manage the privacy controls of their data and how it's used, who has access to it, how it's encrypted. So we help them do that. But on our end, we cannot access or look at in any way the data that's on AWS. And I think that's what really helps me and my colleagues as we engage with customers and partners, is knowing that, we really ascribe to that sanctity of data privacy and confidentiality and security.
So, and I think it's probably worth noting just in general that not only is AWS pretty good at that, but provides a suite of optionality that has become kind of the gold-plated industry standard about how to handle that. So I'm pretty sure I can upload data to AWS and have AWS manage my encryption keys, or I can manage my encryption keys. I can have virtual private networks where I'm VPNing into an infrastructure that's set aside. And there's all of these options that Amazon has really been a market leader in, even before they got into healthcare, on how to do private cloud computing in a way that leverages the data centers, but in a way that makes it probably, I don't know that you can say this, but I can, probably better than the security that a lot of these hospitals have on site with their IT systems. More formalism, more constraints, more discipline. And of course, that's, we've seen a lot of these hospital systems have malware attacks and everything else. So these are real threats that Amazon does an extraordinarily good job of dealing with. Of course, hackers are hackers, and someday there could be an emergency. I think AWS certainly has a reputation for discipline in this impact. And you have been, I'm so jealous. I really am that you were at the first Datapalooza. That's so cool. It's so cool. And I've heard things about it because I think I was at the second one, or maybe the third one was my first. I can't really remember. They all blur together as in general, just a wonderful time. And even more so now that we're working more with Academy Health, so we're kind of involved. And I didn't get to see the speakers this year. I was just doing the interviews and everything else. So they're becoming more and more of a blur, but in that blur is this continued collaboration with patients trying to make things. Can you say more about what brought you back to Datapalooza this year?
Glad to. So I think that the two agenda items that I was involved with, one of them was the reactor panel in the opening session, and that was with Vindell Washington and Andy Bindman and others. And I think for me, that was very gratifying to be able to follow our HHS leadership. So Andrea Palm and Mandy Cohen and Major General Claude Fredericks, to be able to respond to what they shared around key initiatives and developments on the policy side for health and open data. And then the second reason was I was also very privileged to be able to moderate a panel with Darshak Sanghavi from ARPA-H. You might know he's leading the HEROES Value-Based Care Initiative. Aaron Holvey, who leads infrastructure at PCORI for PCORNet, and Esther Farkas, who is at Unite Us. And they're, I think, a key player that helps connect social needs data from the community to the clinic. So 2 reasons brought me there, and I'm happy to talk more about those 2 sessions if you have any questions. Oh, you're on mute, Fred.
I forgot to say, my apologies. I have a grocery store being installed underneath my building, so I'm going to mute myself, and I'll have to apologize for turning off my audio occasionally, but it's so that you don't hear the little jackhammers that are going on downstairs. So please, assuming someone wasn't there, and I was there, but I was in another room, so I didn't actually get to see it. What was the first section like? What was your summary of those content?
I was really glad to be able to hear from our leaders, and some of my takeaways include the real emphasis on the need, and this was Andrea Palm, DevSec of HHS. She spoke about the need for interoperability in human services, right? When we look at interoperability of data, a lot of that work has been in the clinical and the claim space, and that's necessary but not sufficient as we look at how to really harness the value of data that's outside of the clinic for better outcomes. So I loved hearing that. And I think some of the specifics there where Mandy, Dr. Cohen, weighed in, and she talked about the progress we have made. It was good to be able to see that I think it was like 90% of ED visits right now are able to be shared within 24 hours, right? That data is tracked, it's interoperable. I think that's really important, as well as some of the other progress we have around public health data and reporting and case management. I think that I remember Paul Fredericks, he's from the White House, and he spoke about, he had a reality check that it's important for us, right? He talked about his own father, who's in his 90s, and he gets a voicemail from their provider that, there's something important that he needs to go into the clinic right away. They don't share any information with him. They also, first do the sharing by mobile app or on your patient portal. If you're in your 90s, you may not even have that type of access. And so the reminder there, I think, for all of us in the room, if you're in industry, if you're in government, if you're on the academic medicine side, is as we work with data to create these innovations, and as they need to be really user-focused, are they able to be used by those people who need them most, including those who may not be digitally savvy? So I thought those 3 takeaways really stuck in my mind.
So if I could further kind of summarize, I think Dr. Shaikh is talking about problems that are really well understood in the industry. And if you are living outside the United States in a country that has a public health system and they want to understand how to intervene and see patterns in data, well, organizations like the NHS in the UK have multiple EHR systems, but they can essentially tap into that data and they can access it. And unfortunately, because we do have what's called a third-party payer system, a huge amount of the data that transfers on a daily basis in the United States is medical claims, which is when you go to see your doctor, you assign to them the right to bill your insurance company, they do so and they communicate, well, this is the services that Fred Trotter received when he went to the emergency room or something else. And that data is, I like to say, financial data masquerading as clinical data. And it's very valuable because it's one of the few data sets we have at scale, but it's not nearly as helpful as the contents of an electronic healthcare record. And again, unfortunately for patients, historically at least, hospitals and healthcare systems and even clinics have regarded the healthcare record as their asset and something that is to be hoarded, so that patients are beholden to the fact that they have to go back to the same source of their healthcare. And that's part of the problems with having a for-profit healthcare system that are well understood industry problems. And one of the things that I'm generally excited about players like AWS getting in is that when they offer interoperability services or data processing services or some of these things, they are addressing some of these very fundamental problems in the healthcare system. So sometimes we do the things out of order. I wish I could have predicted what you would have said so that someone could hear that before. But if you're a patient and you're wondering, well, why are we talking about claims data? Why are we talking about the EHR record? Why aren't they the same thing? Some of these things are limitations about the way our healthcare system works in the United States, and trying to ensure that despite these weird, historically, this is how we set things up, that you as a patient are getting the best care and that your data is working as hard for you as possible. That's, I think, some of the most exciting process that's happening across the industry. And the fact that AWS, which I think is probably demonstrably the largest computer infrastructure company provider in the world at this point, is offering the kind of services that we're talking about is extraordinarily good news. With that, you were talking about a second session. What was in your second session?
So this was a great session that I was able to moderate. And the focus was looking at a learning health systems approach to clinical and community health. And so I set it up by talking with our panelists around, we've seen the seminal report, Crossing the Quality Chasm. IOM released it in 2001. And its recommendations at their core still hold true today, right? That we need to build a better health information infrastructure to redesign our care for safe, effective, patient-centered, and more equitable outcomes, right? And that was like over 20 years ago. So the charge I gave them was, how are your organizations, ARPA-H, PQuarry, and Unite Us, looking to make data more actionable? And I think a few of the takeaways were really telling, right? I think it was Aaron who talked about something that I really feel, and I think many of us do, that, we've been working on interoperability of data for, over a decade or two now, right? And as we look to go beyond interoperability and data standards, Aaron talked about this notion of, let's have interoperability of services, right? And that spoke to what, Mandy and the DEC secretary shared up front, which is interoperability in human services. Well, how do we do that, right? It starts with something which at Amazon, it's in our DNA, having a customer obsession, right? Be it patient, individual, persons in the community, their families. We need to really start with them to think about, well, what is their need, right? Is it around a specific use case? And an example I like to share is the work we're doing with Rush University System for Health. And so they came to us a few years ago. They were looking at how to improve more equitable surge response during COVID. We helped them stand up a dashboard that connected operational data, which beds are available, where providers are free across 20 or so different hospitals, and a dashboard for the health department so they could provide that more equitable surge response. And it didn't matter if you could afford the care or not. They went ahead at Rush and they got funding from RWJF, Robert Wood Johnson Foundation, to be able to look at how can you create a health equity analytics platform. So for them, they started with, I think it's like a more than 15-year death gap in West Side Chicago between Black and brown residents and white residents in cardiovascular disease outcomes. And they said to us, hey, we want to be able to connect our clinical data, they're on Epic, but also potentially scale the system up to partners who are on Cerner and other platforms. Connect that with data from social needs, both the individual screeners that they're collecting, but also can they look at how the predictive validity of group and population level drivers like availability of food, housing, jobs, how that might affect the 10-year ASCVD risk calculator. Because that's a calculator that's evidence-based. It shows your risk of cardiovascular disease. So we help them set up this platform. It takes any kind of data, really. It also takes data from remote patient monitoring devices. It aligns with Fire data model, so it allows you to be able to make the API calls to bring the data together. And then they were able to develop machine learning models that looked at, can you actually improve your risk prediction of cardiovascular disease with those social drivers? What's really cool is that they're also conducting focus groups with their providers because they want to figure out how to make it easy to then provide a decision support nudge to their providers at the point of care when they're seeing a patient. And that patient shows they have risk, not just of cardiovascular disease, but they may need access to food. And then what that information would look like. And I think, Fred, that's what's really important, right? That's what's taking it beyond interoperability, beyond the cool things around machine learning and prediction of risk, to how can that information actually be used at the point of care to move the needle on outcomes. So that's just one example, but I think that speaks to what the panel was talking about that I was moderating, is how do you take data and make it more useful and usable?
Well, and so many of the things you're mentioning there are kind of longstanding issues. I will try to make sure that the IOM report is in the show notes. I think just in general, Pecori and links to the other people who were on this panel with you would be great. It's interesting, the term health equity has been used as I'd say a term of art in healthcare for probably at least 10 years, probably 15. And in some senses, it goes back all the way to the IOM report, which the IOM report showed that there was really a significant patient safety and quality problem. And IOM, of course, stands for the Institute of Medicine. And it really was this watershed event where the healthcare system was waking up to itself and recognizing some of the problems that it had were very significant. And the term health equity, as a term of art in the healthcare industry, has really meant some very specific things about whether or not patient rights are respected, irrespective of people's race or even ideology, or a dozen different things that really shouldn't impact healthcare, but we have fairly good evidence do. And of course, in our politically controversial thing, the term equity has now become this term of debate in our larger politics, which is kind of unfortunate for us in healthcare, because I think for a pretty long time, we've had some pretty, narrow understanding of what this meant. And we had consensus in the healthcare industry that this was a problem and that it deserved to be worked on and was not controversial at all. But I think that the work of all of the organizations that you're talking about is precisely the kind of work that has obviously been necessary in health equity. And I think you touched on probably like 7 different things. One thing is that in our healthcare system, talking about kind of the way things have traditionally been set up, the people who provide food pantries and other social services have not been communicating in a kind of formal way with the people who are providing medical services. We used to have the same problem with people who provided ambulance systems. For historical reasons, the people who did ambulances were associated with the Department of Transportation, right? And so there's all of these old decisions that continue to echo that hold us back from having a kind of, let's call it a world-class healthcare system. And I think there's obviously, almost everyone agrees that there's some big policy reforms that we should probably be doing to fix some of the things that we would label as health equity. But there's other things that really are coordination of care problems, data problems, and the solutions that we're talking about here on this call are really significant steps towards addressing some of those things. So I'm really excited to, and I wish you could answer, I'm not asking this question because I know it's totally unfair, but I wish I could say, well, like, how do AWS GPUs end up impacting health equity? Because there is a tie, right? There is a way.
I can share some examples.
Well, go ahead.
I'm not going to give you the direct link between the electricity that's powering the GPUs to equity, but there's certainly an indirect link. Very proud of how we recently wrapped up a 3-year fund to be able to provide, I think it was $60 million total for proofs of concept on the cloud for health equity enabling innovation. So an example, because I think over 300 projects were funded. One example of a project that was funded is what we did with Rush. We were able to provide those credits to the team there for that project. But another example is work that's being done in Kaiser Permanente. So their Health Research Institute in Washington, they have a dynamic research team there that's looking at funding from NIMH, mental health. And what they wanted to do was link data from their clinical record with data from credit bureaus. And the reason was to improve the prediction of suicide risk models. Because when you have a bankruptcy, when you face a financial challenge, that is in our credit record. And so to be able to securely and privately link that data and get the right IRB approvals, the actual patient consent is one thing. But technically to connect that data, that's where I'm really excited, because the team there was able to use a service that is called Clean Rooms. And that service allows you to be able to keep the data within each organization. So in this case, Kaiser Permanente Research for the patient clinical data and the credit bureaus for the credit data. It doesn't store the data in the other organizations part of the cloud. Instead, it reads the data from where it lives and applies restrictions that protect each participant's underlying data when the query is run. And then it'll just return the results. And those are either anonymized or the patient identity is obfuscated. And so I think it's technical solutions like that that make the actual social process of data sharing, data use agreements easier. And in this case, this researcher is now able to link the credit data with the patient data to improve machine learning risk prediction of suicide. And that was funded by the health.
It's amazing. I should admit, we got an AWS scholarship for when we were, I think my company's about 12 years old. I think we were like 3 years old. We got an AWS scholarship, and it tremendously helped. And we still use AWS as a result. I hope you've probably made the $30,000 back over the course of the last 10 years. But I do think AWS's commitment to supporting healthcare, and by the way, we got that through our incubator. And I do think that working with an incubator that has a relationship with AWS is a really good idea that we did, and we found it really successful. And that scholarship that we got for our AWS expenses was really, really helpful at the early stage in our company. And let me just thank you, because I think there's two worlds of big tech. And in general, I think that there is a business model out there that the basic structure of the business model is that big tech takes advantage of people using their data for profit. And then there is the parallel universe of big tech, which is that in general, the data is used to the benefit of people. When you want to do that and you want to do that securely, you start to have to jump through all of these hoops. And I love the name of the company you just mentioned, Clean Room. I mean, what a great way to say what they do and that implication.
So that's a service on AWS. It's not a company, but that can be used by any company.
Even better. So the seeing AWS do those kinds of things is part of what gives me hope for our big tech. And of course, I can't endorse, and I'm sure you can't either, everything that Amazon has ever done in all of its business lines. But at the same time, I think emphasizing and celebrating when a company like Amazon does amazing things to help patients, it's really, really good news for the whole ecosystem. Obviously, I could literally talk to you for 2 hours about that one topic, and that could be the beginning of a longer podcast, but we only have so much time. I think it's pretty much guaranteed that I'm going to see you at a future Datapalooza. May not be next year's, but as long as they keep having the conference, I'm sure we will see each other there again. Hey, and listen, this is the kind of content and stuff that you're going to see at Datapalooza. So if you're wondering whether you should come next year, please do.
Oh, I will not wonder about that. I want to keep my streak alive, Fred.
Oh, how long is your streak? Have you been to everyone? All of them?
Every one. I think it's in its 15th year now. And so
I am jealous. I'm jealous of being involved that early. And I'm also jealous of the time and ability to be that consistent in your career. Because there were some years which is like, not happening this year.
But I think it's a testament to the vision that was laid out by HHS leadership and all the partners, I think, who have been involved, both public sector and out in the field, nonprofit and industry.
Well, thank you for helping to lay out that vision and articulate that vision. And being there for the early days to do that. So I really appreciate it. Oh, and you were served on the Datapalooza Planning Committee. So you're working on it right now too. So thank you for that as well.
Oh, absolutely. Can I talk a little bit about what I'm excited about that's in the pipeline now with TEFCA? Because I want to mention...
Please. Well, first, if you don't mind, otherwise I'll have to do my little rant about what is TEFCA. And I don't even know if I understand it that well. So please tell me first, what is TEFCA and why you care?
Well, the trusted exchange framework, right? It's a common agreement that allows for better exchange of data. And I think it allows us to be able to look more clearly at the broader picture of healthcare as an ecosystem, right? So it's clinical, it's community, it's public health, and it has different elements. And I think it's been really thoughtful to see how TEFCA has evolved so that its usefulness, its potential for driving meaningful interoperability has only been increased. And I think an example of that is the recent expansion of TEFCA around healthcare operations. And what that relates to is the encouragement of data sharing around population-based activities related to healthcare costs and the reduction, protocols, case management and care coordination. So information, I think, such as this is really important because it allows us to think through as you look at clinical data, social data, claims data. You can also look at this operational data to get a better understanding of that patient journey and where clinical, community, and public health organizations and players touch on that patient journey. And I think because the data will hopefully be able to give us a richer understanding of that patient, I think it gives new meaning to this idea of a patient 360, right? Having a better understanding of patients and their care journey in the context of what they're going through and what the organizations that touch them going through. So I think it's kind of exciting to look at TEFCA, not as just a destination, right? But I think TEFCA itself as an evolution has been really important.
Well, and my take on TEFCA, there's been drama about TEFCA. People have been talking about, well, who gets to be on the network? What do they get to do things for? And that drama, I think, has detracted. I think in some senses, the drama itself, it doesn't seem like it at first, but the drama itself is good news. And the reason is that drama of who gets to have access and for what purpose, and we don't necessarily all agree about what is good to move around with healthcare data. That is a problem that you get the moment you start to actually move healthcare data around. And the reason why we haven't had those problems before is because we had massively siloed systems where the data just stayed where it was. And the reality is that if you have an ecosystem as large as the health IT ecosystem, we are not all going to agree on what is
right.
Exactly.
That's right. That's exactly right.
And there are cases where things are in the patient interest, but not in the doctor's interest. Things that are in the hospital's interest, but not in the doctor's interest. And
but it'll help us move from this idea of bespoke innovation in healthcare, right, to I guess scaling that innovation, making these solutions repeatable across these touch points where data can be used and leveraged for improving care. I think that's, and it is a journey rather than a destination, even from a policy perspective.
A great way to say it, a journey and not a destination. And the kinds of problems that we have now, talking about the journey part of it, are the kinds of problems that will work themselves out. But when you have a siloed system, it wants to stay siloed.
Right.
And so, people will complain to me about, well, I don't think the TEFCA handled this way, or, oh, this is, people disagree. And I'm like, oh, thank God, finally, these problems are coming to the surface.
That's right.
Not like we didn't have them. We always had the problem.
Exactly.
Right? But we solved it by just saying no.
Yes.
No, the data will not move. No, the data will not serve the patient. No, the data will not, all these kind of things. So from my perspective, like every time I hear somebody complain about TEFCA, I'm like, finally.
Yes.
Finally, we have something to complain about. That is such a good progress in the industry. which is not necessarily the reaction that I think people want to have when I'm trying to, Fred, you empathize with my problem here. I don't like this, but I love it. I love seeing those problems because they are the problems that precede good things. They are TCP IP not working on this, hardware, and then later we have the internet, the World Wide Web.
Right. That's right.
Always amazing things. They always have growing pains.
Mm-hmm.
I have taken up, I think, a full 10 minutes longer than I promised you. Your interview would be, Dr. Shaikh. Thank you so much for joining us. I really appreciate your time, and more importantly, your time for this interview, all the things you've done for patients in this country. Thank you for your service in the government. Not many people have the patience to do that. So thank you specifically for that. And I really enjoyed chatting with you. And I hope, please find a way to hear more. I think you're on LinkedIn. There's other places people can read your thoughts.
I'm on a National Academies working group as well. That's been pretty exciting because we're hoping to put together some recommendations around how to take interoperability to the next level. But thank you, Fred. I appreciate this opportunity. I hope it's helpful for the audience. And I look forward to meeting you in person at the next Palooza or sooner.
All right. Thank you very much.
Take care.